Welcome to the Good Good podcast. I'm your host, Dee Talley, mama, licensed acupuncturist, herbalist, and embodiment coach. Here we dive deep into the realms of energy, consciousness, awareness, empowerment, and personal transformation to help you create a more vibrant and juicy life. Hello, everybody, and thank you so much for joining us. This is the Good Good podcast, and I'm your host, Dee Talley. I'm really excited because I'm here today with my colleague and friend, Dr. Patrick Boswell. He is a doctor of acupuncture and Chinese medicine, a licensed massage therapist, a Doulas certified doula, and he runs a private practice in Rochester, New York. So welcome, Patrick.
Hello.
Yay.
Thanks for having me.
Yeah. Okay, so in true Good Good podcast fashion, every single guest has the same first question.
Excellent.
And so we talk kind of like ad nauseum about energetics, embodiment, and living a really vibrant life. So my question to you is, what is your good good? And when I say that, I'm asking you, what are the sense-felt things that you can't buy online that light you up?
I would say my good good is community. In whatever way that ends up being. I play music. Actually, that's what that is in the back. But I play music, so like playing with my bandmates, like that's good good. I think playing games with friends. I'm a big tabletop board game. I'm a huge nerd. So like doing that's like a time when I'm like feeling my best. And then, I mean, like we're talking about now, I think birth work in general is, so vibrant and so ups and downs and highs and lows. And I think that's why I like it so much, is because almost no matter what, it's intense. Whether it's good, whether it's bad, it's very raw and it's very intense.
Yeah, absolutely. There's something so interesting about birth because it's like you, as a person who's birthed two babies, when you're in that space, you're in like liminal space where it's like there's really no time, or it's like a very interesting experience for sure.
Yeah, I mean, and you're supposed to be. So there's this woman who I've studied with. She was an old lay midwife in, I think, like Kentucky in like the late 80s, early 90s. And she has a whole brainwave kind of discussion about like what brainwaves you're in at different stages of labor, and being stuck kind of in a higher brainwave like beta waves, like kind of active what we're doing right now, versus like delta, which is like the deepest, prevents you from doing the work that needs to be done. And you're kind of supposed to be high on your own supply. It's your body's way of pushing your consciousness out of the experience to let your body do the physiologic function that's supposed to happen.
Yeah, that is so amazing and makes complete and total sense. Now, you knew that you wanted to work in the birth space from like basically the beginning. And
pretty much, like even when we were in school together, by the end of the first year, I was like, I think this is what I want to do.
Yeah.
And I considered becoming a midwife afterwards, but as you well know, another 3 to 4 years of school after what we did, I probably would have set myself on fire.
Yeah, fair.
And so I decided to become a doula, which doesn't take necessarily like formal higher ed training. And when you're the doula, you're not responsible for the medical stuff. When I'm there, I'm doing acupuncture because I have credentials with the local university hospital system. So I'm credentialed with the OBGYN department of the University of Rochester. So I practice inpatient right on the labor and delivery floor, and antepartum and postpartum.
So amazing.
High risk people, antepartum,
Amazing.
and then doing labor and delivery at Highland and Strong Hospital in the city of Rochester. Yeah, so I'm right in the room.
So what was it about the birth space that really intrigued you? Like why, because I also looked up statistics about men in these spaces, and obviously it's a really female dominated field. So like 11.2 nurses are male nurses. That's not even labor and delivery nurses. 5.7% of doulas are male. So like what was it that you were like, yes?
Interesting. I'm actually kind of surprised at even the doula statistic being as high as it is. I mean, and I do want to preface by saying, like, I think it should be a female-dominated space. You know what I mean? Like, I think there's room for a couple of men, but I don't necessarily think it should be like, I don't even necessarily think it should be 10%, especially like in the doula realm. And there's, a couple of male nurses I've met in labor and delivery over the years, but not many of them. But I think what interests me is, my mother always told a story of when I was 2 years old, my sister was being born, and at that point in history, you were allowed to be in the hospital, like with your parents. And so I was like jumping on her hospital bed as she was delivering.
Oh, wow.
Was the story that was there. And so I feel like birth and pregnancy have always fascinated me and really intrigued me. And then when we're going through acupuncture school, even just something as simple as like learning the points, you're going through the points and you're learning actions and indications and like what these are for. And every once in a while, you'll come across the point where, the point will say like it does this and this and this, and then it quickens labor. And then we move on. Mm-hmm. Because nobody's really doing that work in the acupuncture space, especially in terms of like active labor and delivery. Mm-hmm. There are some people doing pregnancy pretty regularly, and there's a ton of people doing fertility, but labor delivery kind of gets overlooked, and we don't really learn much about it directly in school because, the professors were always like, well, maybe you'll see this once if you're lucky. Mm-hmm. So like, don't really worry about it.
Right.
And so we were learning about these things and learning about, treating nausea and treating pain and kind of all of these pregnancy symptoms. And I started getting interested in like, well, tell me more about that. Mm-hmm. I want to know more about like, why is this cursory information? Why aren't we digging in on here? And then finding out that like, basically nobody's doing the work. And then started getting into birth, started like watching, The Business of Being Born was like one of the movies that really kind of pushed me towards it. Mm-hmm. Learning that like, learning at that point that a lot of, pregnancy care is, well, you're pregnant. What did you expect? Mm-hmm. Or it'll be better when you're not pregnant. Just deal with it for now.
Right.
And so learning that there were things that we could do to change that and make pregnancy more comfortable and make it not as, it's not supposed to be a horrible thing. It's not supposed to be miserable, just like everything else. Like menstrual cycles, they're not supposed to be miserable. They're not supposed to be super painful. They're not supposed to be super heavy. They're not, these things, I call them common but not normal, where just because it's ubiquitous within a society for something to happen does not mean that it is normal physiology. And if it's not normal physiology, then we should treat it as pathology and we should work on that. Mm-hmm. And so pregnancy kind of falls within that, birth falls within that, to make sure everything is optimized and that you're as comfortable as you possibly can, and we're treating to prevent future illness.
Mm-hmm. Mm-hmm. Yeah, it's so true. And I think that, like, I even had this experience when I was going through my pregnancies of if something came up and you bring it to the attention of, your practitioners, they're kind of like, oh, well, you won't be like this for long. Like, It's just considered that, like, small amount of space in this whole big process. Mm-hmm. And it's like, well, what you're saying is we should do better.
Yeah,
it doesn't
absolutely
have to be like this.
Yeah. The whole point of medicine, no matter what field you practice, is to treat pathology. Like, that's what we're trained to do. We're trained to recognize and treat pathology. And so if we're seeing pathology, why are we doing nothing? Mm-hmm. Mm-hmm. And, to give credit where credit's due to OBGYNs and midwives and things like that. Unfortunately, it's just kind of their training. Like, it's not their fault. It's most of the time they don't really have anything that they can do. Mm-hmm. Like, most of the time for OBs especially, like, it's surgery or it's birth control or maybe an antibiotic. Mm-hmm. That's pretty much what they got. And so
like, these are bigger issues.
Yeah. And so, they're not, it's starting to get better, but they're not referring to pelvic floor PT. They're not, we're not referring to us. Mm-hmm. We're not referring to, Cairo or this or that, they're not referring to mental health services, Again, that's getting a little better, but it's still just like, do you want an antidepressant? Mm-hmm. Do you want Zoloft for the rest of your pregnancy?
But you are doing this important work out in Rochester. Do you get those referrals? Because people are like, hey, Patrick's doing this and this isn't right and we want better. Like, are the OBGYNs and are they referring?
Yeah. A lot of them are, and it's partially because I have, hospital privileges. And I've connected with a lot of them. And then I used to have 2 locations in my practice, and one of them used to be in a University of Rochester outpatient facility. So I used to actually work in the same office as the midwifery group that's out of that, which has like 20 midwives at this point. And then there was an OB group, and then there was a pelvic pain specialist group. So I used to work in the same office as them, and, you know, would get to communicate, and they would see me around, and they would ask me questions, and I would ask them questions, and we would connect. And I would go to other practices and kind of introduce myself and talk to them and do that. And then I've been a doula for over 10 years because I did my doula training actually when we were still in school. Because I knew that's what I wanted to do, and I was like, let me just do this now. So my oldest doula baby actually just turned 10.
Oh my gosh.
Yeah,
my
like 2 months
oldest
ago.
doula baby. That's so amazing.
Yeah. So I've been doing this for like 10 years. And so between that and the birth community in Rochester is really great. We have a ton of doulas. We call the Doula Cooperative of Rochester, which has been around for like almost 20 years.
Wow.
I think, or a little over 20 years. And so there's like dozens and dozens of doulas and some really great people that train doulas in Rochester that are like DONA trainers and childbirth educators and people that train childbirth educators. And like the birth community in Rochester is very unique, especially for a city this size and for a community this size. But it's a very birth oriented city that ends up being able to push, you know, hospitals even in protocol because we have those connections. There's doulas who, you know, have been doing this for 20 years that are part of committees within the hospital system for breastfeeding and birth and like trying to like give their input to set parameters on like what you can eat and how you can eat and water intake and this and like kind of all these things that
that sounds so progressive. Like we need to take a line from that playbook, because here up in northern New York there are not many doulas. I think there's maybe 1 or 2, and many of the doulas actually come from Burlington, Vermont. And it's a problem because I see a lot of patients. I love treating pre-birth. And there's a lot of patients that ask me about where can I find a doula, and it's like it's really, really difficult. I think it's so amazing that it is so progressive in Rochester, and that like this feels very like collaborative in a way, because here it does not feel like that, and I think in a lot of places it doesn't feel like that.
Absolutely. And I mean, and that's the culture that's been built. You know, we got to give credit to the women who 25, 30 years ago were doing this before doula was even a term. There's one woman who I absolutely love. She's a good friend of mine. Her name's Molly Deutschbein. And, you know, she talks about being a birth assistant, you know, and kind of just being like the lady that lived down the street that would come to your birth with you, you know, 30, 35, 40 years ago. And so it's not something that was built overnight.
Right.
And I think a lot of it's community. It's based on community. Like having the doula cooperative is huge here because it instills a sense of community, and it benefits everybody in the community. Where part of the doula cooperative meetings, especially when we first started, was like, or when I started going, was like you would show up, there'd be 10, 15, 20 people in there. I'd be the only guy, which I'm used to being kind of the only man in most of these classes and seminars and spaces and things like that. And we would tell birth stories. They would say, well, this is the birth that I just had. What do you think? Or it would be, you know, a trauma dump, you know, because there's a lot of secondary trauma within healthcare in general, but a lot of secondary trauma within birth because there's a lot of violence and a lot of obstetric violence and birth violence and things. I think there was a study, Doulas published a couple of studies, but I think there was, one of them was, you know, 25 to 30% of people report some form of physical or mental birth trauma associated with a birth. And then there's secondary, so the other people in the room, the partner, like a lot of births, you ask the birthing person 6 weeks, 8 weeks, 6 months later, and they're like, oh, it was great. And then you ask their partner, and they'll go, oh, well, I saw them do this, and this, and this, and you were making this, and, you know, the birthing person on purpose is so out of their head that they oftentimes don't even realize what's being done to them or what's happening. But the partner is fully there. The nurse is fully there. Watching what's happening. And it's these people that have no power, you know, the power structure. They're very down on the power structure, which is unfortunate because technically the patient has the most power.
So have you witnessed it? Have you been?
For sure.
And how much like advocacy and how much can you do?
I mean, I can do more than the average doula because, I have a medical background and I have credentials and I can speak their language and I can do all that kind of stuff. But I'm still not an obstetrician.
Right.
Like, I still, I have credentials with the hospital. I make too much of a fuss or I do this or I do that, then, like,
they can you.
Yeah, who knows what happens. But I can definitely kind of be like, oh, why are we doing this? Like that kind of thing. That's oftentimes one of the best ways. If you're at a birth, you're the person giving birth, you're the partner, you're the doula, you're the whatever. Why are we doing this? What are we doing?
That's a good tip. Mm-hmm.
Hey, can you explain this to me?
Mm-hmm. Yeah, because it kind of makes space for it, right? Because things always feel like they're on fast forward when you're in these spaces. So it kind of gives that pause of like, okay, hold on a minute. Mm-hmm. I think too, a lot of people think that a lot of things are emergent in birth, and so it's like this like ball that's rolling down a hill, and it's like very often it's not quite an emergency.
No.
You know what I'm saying? But it's somehow the energy of emergency is.
For sure, absolutely. And again, to give like OBs and midwives credit, like most births, if left alone, they're fine. I think there was a study, it was like 100 years ago even. I don't remember who did it. But she basically just like left people alone until the absolute last second. And I think it was something like 10% needed intervention of any kind. And she even claims in the study like that was probably even a little higher because I got nervous. Mm-hmm. So it was probably more like 5-6% that actually needed real medical intervention. When I'm talking about birth with people, I think the most important information that you can know about birth is that people in comas have vaginal births.
Yeah, like your body just does it.
I think that's like that sums it all up, is that like if you can get out of your own head, things just happen. Mm-hmm. And there's not necessarily dangerous, and it's not necessarily complicated, and it's not necessarily all of these things, but we make it these things. And, kind of to go back to give them credit, like they see things that went every once in a while, they see something that was like perfectly fine, and all of a sudden, boom, within 2 to 3 minutes, things are very different. People are in danger of dying. Mm-hmm. And it changes the way your mind perceives the situation. Mm-hmm. So it's like, it's not even necessarily their fault.
Yeah. I love that you're giving credit like where credit is due with OBGYNs and midwives, because this is like, thank God for their training, because it saves lives.
100%. And I think it's a very hard job. I mean, imagine working 12 hours overnight, several days a week with a completely unpredictable schedule.
And a level of intensity that's really high.
And you need to have a level of perception constantly. You've constantly got to be like focused, because again, if you're not focused, all of a sudden it could be that 1 in a million case where, within 2 minutes, if you didn't hit that button, something catastrophic is going to happen.
Yeah, exactly. Yeah.
And, it's a fine line, and, we have too much intervention in this country, especially in my opinion, and like the WHO sent a letter to the ACOG or something, which is American
College of Gynecology.
Yeah, it's American something gynecology. It's like the OB's professional
like
group,
the
whatever.
Standard of care, right? Like that's what it comes from the ACOG.
Yes, like that's who sets standards and stuff like that.
Yeah.
But they sent one to ACOG like 10 years ago that was like, hey, your guys' like complications in birth and your C-section rate and your child and mother mortality rate is insane. You've got to slow down.
ACOG sent that to who?
No, the WHO sent that to ACOG.
Wow. Okay.
Yeah, and said you're doing too much. You've got to wait. Like they said, their recommendation was wait. You need to wait more. You're getting too stressed. You're going too fast. Mm-hmm. You're expecting things to move at a pace that's not reasonable, and it's causing you to do.
Because you and I both know that birth is not fast a lot of the time.
No, not necessarily. And
it can be,
for sure. And I mean, and the thing is actually one of my other passions is like evolutionary biology and like anthropology and things like that. And there's birth anthropologists and people who kind of study birth within like hunter-gatherer societies and kind of indigenous cultures and things. And realistically, birth is kind of supposed to look like birth for any other mammal. It's not supposed to be 6 hours, 12 hours, 24 hours, 36 hours. it's too vulnerable. If you're in the woods, it's too vulnerable. You know, we live in community and things like that, but it's too vulnerable to be that exposed for that long. Birth is supposed to be a couple hours from like active labor to holding a baby. Most births nowadays aren't like that for a myriad of reasons, to activity levels, the way that we use our pelvis, pelvic tension. Most of it is up here, in my opinion, but modern birth is not necessarily fast. And, you know, they'll say like a centimeter an hour. I've seen births go from 2 centimeters to fully dilated in 30 minutes. And I've seen births go from hard posterior and closed to, you know, take weeks.
Yeah, there's no right way.
No,
right?
And there really is no standard. Like, because it's so variable, there's so many variables.
So what I kind of want to go back to talking about you in these spaces, and I want to know, like, what do you think you as a man brings to the birth space? Like, what's the difference in dynamic? What's the difference in energy? And do you think there are misconceptions about men in birth spaces?
So where I think men have a role in this is, or if there was a benefit, a pros cons list, what I think it would be. I think one of the big pros is I've never done it and I'll never do it. And so I have no preconceived notions.
Yeah.
I have no
birth story of your own to
I have no birth
impose
story of my
upon.
own. And I mean, so many people that get involved in birth work, especially doula work and things like that, they either had a very traumatic birth and they don't want it to ever happen to anybody ever again, and they want to be there to help, or they had an amazing birth and they want to share that with everyone else, and they want to make sure everybody else gets that too. I've never had either one. I've been, you know, and so when something is happening, I have no skin in the game, so to speak. You know, I know what you're feeling. I've been there. I have no idea what you're feeling. I've never been there. I believe everything you tell me. With no opinion of my own. And I think a lot of people, especially when they've had births, you know, something happens and it kind of triggers them. Something is happening to another person. For me, like, it can be absolutely traumatic, but like, it's not traumatic on a personal level to me. And so I think my ability to stay objective the whole time is kind of a benefit in a lot of cases. Yeah, so I mean, I think that's the main like benefit of like a male in the space. Especially in like a assistant, like helping kind of space.
Yes.
I mean, I've definitely had people before and friends and things that, like, actually the woman who I was her doula for all 3 of her babies, and she was my first. She's a friend of mine. I remember with her first, she went to this like yoga retreat or something like that while she was pregnant, and she said something about like having a male doula, and the woman was like, you shouldn't have a male doula, like that doesn't exist, / like they can't be there for you, they can't do this, they can't do that. I think empathy is a universal, and like I don't necessarily need to, you know, have gone through exactly what you've gone through, which nobody has gone through exactly what you've gone through. Every birth is a unique experience, you know, and as you know, each birth that even an individual has is a different experience. You know, no 2 births are the same, even for the same person. But I can be compassionate, and I can, you know, use my skills to try and diffuse what's going on. I think there's also I haven't heard it much. It's only been like one time where, you know, it's like a sexual thing where they think it's like, you know, you're just there to like look at people. And I'm like...
Right. Which is like so...
Which is
like
very
icky
weird
to me.
Yeah.
That's a weird one for me.
Yeah, I'm like,
well,
okay.
So I was thinking about how, you know, as a man, I think that you naturally will bring a very grounding energy into that space. You're extremely well trained, of course, and so the combination of those things, I think, would create kind of like a magical experience, I would think. And what you said about not having your own story makes me think of like beginner's mind. Like you're coming into every room with beginner's mind. Like no preconceived ideas, no nothing. You're just there for support. That feels super refreshing to hear. Yeah, that feels amazing to hear.
I've actually been hired by, there was a same-sex couple that hired me where they were like, I think we just need a little testosterone in the room just to balance things out. And I was like, okay, sure. And then there's other people that, I'm also 6'4", and so very large, and so like they feel like it's like a bodyguard in the room, so to speak.
Ooh, yeah.
And then I also have been hired or tasked with helping partners, because if there's a space that I can come from a place of experience, it's being a partner in the birth room.
Yep.
And then having the experience and then the knowledge on top of that to go like, how can I create an environment for this couple to come together?
Yes.
Because so often the partner is paralyzed. They're seeing the person that they love in pain, in intensity, in a space they've never seen before. They don't know what's going on. They don't have the clinical knowledge, the book knowledge to know what's going on. They don't have the personal experience to know what's going on. And so a lot of times they're paralyzed. And they're either sitting there or they're like dissociating and sitting in the corner around their phone, trying to ignore the whole situation because they feel like if they tried to add... They feel uncomfortable, and if they tried to add something, they feel like they would just ruin it. And so they like pull themselves back, or they get kind of this anxious, like I gotta do something, but I don't know what to do. And so being able to like guide and direct them, and like be doing some kind of body work or some kind of physical comfort measure that I'm doing, and then find out what's good, what is working for them. And then have the partner and literally take the partner's hands and do the same thing and tell the person that's giving birth, like tell them, like guide them to make it feel like what I was doing. Yeah, so like really trying to relate to them and get them involved in the experience and make them feel more comfortable.
Yeah, that is such good stuff, because I hired a doula for both of my births, and I remember, so my births actually were kind of, at least the first one was pretty long. But she was like even doing things like reminding my partner to eat and drink, because he was just so dialed in that he was like not taking care of any of his own needs. I think relating to partners, especially if the partner is a man, as man to man, like something about that feels really like therapeutic in a way where it's like, you can relate, like you're like, yes, I've seen this through. You know what I'm saying? I think that's so great.
I understand that you're trying to stay strong for your partner during a time of intensity, but also what's running through your head, and again, ignoring your own needs and ignoring your own feelings in the moment, and which is such a problem with men in our modern society, which I do it all the time. I can't claim that I'm any better, but like pushing through for somebody else. Right. Ignoring your own needs in order to show up for another person.
Right.
And, I mean, even just being the doula, just a doula in general, like, it's just another set of hands. Like you were saying, just like, hey, like, you two are in a moment of intensity. I'm just doing my job. So, like, I can take a step back and be like, hey, I noticed that, like, you haven't eaten in 12 hours. Or like, you want some fresh air? You want to go get a cup of coffee? You want me to go get a cup of coffee? Do you want me to go feed your dogs? Do you want, you know what I mean? Like,
just
that
like
kind
an
of
extra
thing.
helper.
Just like a set of hands. That's why I think a good word for doula, or a good explanation for doula, is like birth guides. Because that's really what they're supposed to be. They're not necessarily there to even create physical comfort and create, they're just there to like guide you through the process. And some of them have better training and body work or this or that, other things. But, at a base level, they're kind of supposed to just be like a person sitting in the corner that you can turn to and go like, is this okay? And they're like, yeah, you're fine.
Yeah.
Just keeping that.
My doula was telling me a story, and actually it was based on a study, and it was like a doula's presence, even just making eye contact through a contraction, promotes better birth outcomes. Totally. Like even just the presence.
Yeah. Well, I mean, and that's the, going back to the like birthing in a coma, why is vaginal birth possible in a coma? Because it's a physiologic response, and it's slowed down by the sympathetic nervous system. Birth is a parasympathetic function. I mean, it's really a balance because contractions are kind of sympathetic, but it's, in general, mentally at least, the mental component. is a parasympathetic function. So parasympathetic, what is it? People know it, rest, digest, reproduce, versus sympathetic nervous system, fight, flight, fawn, freeze. And so sympathetic nervous system, when it's heightened during stress, during whatever, you release a lot of cortisol, you tighten your muscles, you heighten all of your senses, you do all that kind of stuff. And cortisol is an antagonist to oxytocin. So oxytocin is the hormone produced by the pituitary gland that causes uterine contractions in labor, uterine contractions in orgasm, the letdown response in nursing, and peer-to-peer bonding, like pair bonding in humans. And so when you're stressed, all of those things become harder because cortisol stops oxytocin from doing its job. On purpose, it's supposed to do that. It's not a mistake. If you're giving birth in the woods and you hear a twig snap behind you, you better have a mechanism in your body to stop what you're doing, move to safety, start again.
Right.
It's completely doing what it's supposed to do. But the problem is that we're not hearing a twig snap behind us. We're hearing this beeping machine beeping. The overhead lights are on. Somebody every 30 minutes is coming in and talking to us and asking us how we're feeling and asking us this. And then they're jamming fingers in you. And then they're stabbing you in the arm with an IV. And then they're like doing this. And it stresses you out. It's just whether you want it to or not, it just stresses you out. It triggers sympathetic function, releases cortisol, blocks oxytocin, slows things down.
And couple that with the fact that for many women, these are unknown spaces that we've never actually been in before.
100%.
And so you can kind of freak yourself out and think, well, this is intense. This isn't okay. Like something about your body kind of says, oh no, like you're going to, like I had a moment where I remember in my first birth where I literally thought I was going to die. Like I came to this wall and I was like, you might die. And then I said, okay, then I'm going to die. That was the point. That was the transition from full transition to pushing for me.
Yeah.
And so what you're saying, all these things, like the beeping machines, the people coming in, the needles, all the stuff, it's like that in addition to this being a totally unknown thing. And we have, as women, I think we like to people please in a way.
For
where
sure.
it's like, we want everybody around us to be comfortable. So it's really hard. Like when you add all these things together, how do you bring traditional concepts into modern birth? Like, what do you say? What do you do? Are you like turning down the lights? Are you like, everybody get out? Like, what do you do?
The other half, sympathetic, parasympathetic. I mean, usually I tell people, like, when I see them in the office and everything, I say, like, pretend you're a cat. Like, what does a cat do when it gives birth? It runs away, it hides in the closet, it goes under the porch, it shows up tomorrow with kittens. Do the same thing. Like, why does it want a closet? Why does it want under the porch? It's dark, it's quiet, it's secluded, it's enclosed, it's warm. That's part of the reason why most labors start at night, is because we're sleeping. We're very good at relaxing while we're sleeping. That's pretty much the only time we're good at it. And so most labors start at night because we're in a very strong parasympathetic function and our body just does what it's going to do. And so creating that environment. So when you're in the hospital, especially if it's like an induction or something, bring little string lights, bring little pieces of paper or pictures or, pictures of your dog or a speaker with your own little music and like... bring your own clothes, bring, your own pillows, bring, that kind of thing. Dim the lights, hit the mute on the beeping machine, tell people, like, direct all questions to my partner that aren't necessary for me. That's a big one that I think is super important because, like, it not only does it, like, keep you out of it and keep you in your birth head, like keep you in your birth space where like, again, like that deep brainwave where like you're kind of in your own zone, but as soon as you have to talk to somebody, you've got to come up again and then you've got to go back down. So stay down. So if somebody's like, what's your name? What's your birthday? How are you feeling? How are you like, those are questions for them. Don't talk to me unless it's like a direct question for me that I need to answer. If there's a form I need to sign, there's right there. That's what they're for. And so trying to keep within that parasympathetic, pretend you're a cat.
One of my good friends was telling me about how because she has had 3 babies and her births are pretty like fast and she always shows up. She comes in hot, as she says.
That's the other way to do it.
Yeah. And she was like pushing, like on the verge of pushing. And these nurses were trying to get her to like sign the consent forms. And she was like, get this the fuck out of my face. Like I can't do this.
Totally.
So if you could shift one thing about birth in a hospital or how it's approached, what would it be? You only get one.
I think slow down. I think that's really, again, that's like the big thing is that like if we just waited longer, most births wouldn't need intervention. If we're going like, oh no, you've been in labor for 6 hours and you're only 4 centimeters. So? Why? Like, why is that the case? You know, we're very good at figuring out, you know, what's going on, but not why it's going on. Because it can be baby position. Are they sunny side up? Are they, you know, OAOP? That's what we call occipital anterior, occipital posterior. Are they asynclitic, meaning the head's tilted a little bit? Is mom super stressed out and she's holding her pelvic floor? Because that's also something we do when we're stressed is we engage our core. We engage our core. It's a defense mechanism. We can hold a bowel movement. We can hold a baby.
Yep.
It's the same muscles. And so I always say, is it mom's head or is it baby's head? Because those are really the only two things that are going to stop you. Is she freaking out? Or is baby in a bad position? And assessing those things and then making a judgment on those. You know, if mom's Pitocin's not going to do shit.
Yep.
If baby is tilted this way, Pitocин's not going to do shit.
Besides cause a lot of pain.
And more anxiety. Yeah. And so, like, you know, maybe you do some spinning babies type stuff. You learn physical techniques to try and, like, disengage baby in the pelvis and then realign. Or use a peanut ball because the baby's OP and try and get baby to turn and do different things to try and get baby to rotate. Or, you know, baby's super high. And so, like, again, Pitocin on a baby that's super high, what's that going to do? Baby's not even engaged in the pelvis. And
There's so many things that can be done to help these things go more naturally. And I think that because when you walk into the hospital room and the bed is the main focus, right? Like you walk in and there's that bed. It's like, I think we have these ideas where mom's birthing, she gets in bed, she stays there, and that's the main, like, that's her place. Nobody touch her, nobody, you know what I'm saying? And it's like really interesting that is the culture.
And lay on your back don't, you know, and don't move because you've got an IV thing stuck to you, even if, like, why did you have that? Did you, you know, if you're GBS positive and you go in and they're doing antibiotics, you're like, sure. But, like, if you're an induction, sure. But, like, if you're going in and you're, you know, I mean, that was like what your friend said, to kind of go back to that. Like, she waits to the last possible second. I usually say, like, the best possible outcome is probably giving birth on the hospital floor as you're walking in.
Yep.
Because, like, you're in the place where if something catastrophic does happen, you're there. And your baby's there and all that kind of stuff. But you've avoided them fucking with you. You've avoided with them messing with you and slowing things down. And so, you know, if you can go to the hospital past the point of no return, which for most people is usually 5, 6, 7, you know, centimeters, then the body's already so far into action that it's really hard to slow things down in a big way. But, you know, if you're still early and you go in, you know, there's a good chance you're going to kind of, you know, we're kind of all familiar with, like, white coat syndrome, where, like, you know, you go in and your blood pressure is high and kind of all this, but, like, white coat syndrome works for birth too.
Yeah, it's like a cascade of intervention and
like, stay at home as long as possible tends to be the recommendation.
Can you tell us a particularly impactful birth or, like, experience that you've had or something that comes to mind?
Sure. One of my favorites, because I was at both of her births, and she's actually a local chiropractor in our city too, and I know she doesn't mind me talking about it, who works in pregnancy and birth and stuff. And so I saw her for both of her births, and her first birth, induction, like 36, 37 weeks for preeclampsia, magnesium drip for like 3-4 days, like, the, you know, the induction was long. She had, like, retained tissue where they literally had to go in and, like, extract the tissue manually. Just a very long, difficult, traumatic birth. And it was a lot. And I would go in, you know, especially for the first 2.5, 3 days, it was pretty chill. Like, nothing was really happening. And so I would go in, you know, for an hour or two, like, once a day, and check in and, like, do some acupuncture and, you know, see how she was doing. And then when things started, I went back. But it went from this very traumatic first birth and very long, drawn out, to her second birth, where it was also an induction, 39 weeks, which those 2 weeks in general can make a huge difference. So 39-week induction, again, for preeclampsia, or for high blood pressure. It wasn't actually diagnosed preeclampsia, it was just like high blood pressure with a history of preeclampsia. And so things are going, like, induction is started, first day, nothing. I went in, checked, did some acupuncture, things like that. And then second day, got the call of like, hey, can you come in? Like, things are ramping up. And I was like, okay. By the time I got to the hospital, and I probably had like a 15-minute drive, 15 minutes, maybe 20 to like get all the way up to her room from my house. I walk in and she's in the middle of getting an epidural, and I'm like, what's going on? I like missed that whole conversation. Things must have gotten super intense. Mm-hmm. And then, when you're getting an epidural, they usually want like as few people in the room as possible, and there was really nothing I could add to that. So I was like, okay, I'll just step out for a second until it's done. And then I heard a lot of like commotion and a lot of like noise, and then like people started leaving, and I went in and they had stopped the epidural in the middle. They went like, you're pushing, we're not doing this. And she wanted the epidural so bad that she was trying to hide her pushing, and she couldn't hide it anymore. Mm-hmm. And so they were like, well, we're not doing this. And so she still has the like sticky like plastic on her back the whole rest of the time, and she's like bleeding from her back. From the spot, yeah. But they're like, she's pushing. And so, like, I get in there and I'm like, hi, we're doing this. Okay, let's go. And also to say, too, she had denied the magnesium the whole time. She was, like, signing consent forms that, like, that if you don't do this, you could get a seizure, you could do this, you could do that. Yep. But the magnesium just messed her up so hard the time before, which it does when you're on it, especially for days. So she kept denying and kept denying and kept denying. So she didn't do that. And, like, she didn't get an epidural that time, and, despite wanting one desperately. And she had the ability to move, and she had the mental fortitude from, like, not having the magnesium and all this kind of stuff, where she was, like, grunting and moving and literally, like, almost jumping on and around the bed, and all of a sudden she's, like, putting her leg up, and she's just, like, and doing this and, like, moving. And it was so feral, and it was so raw, and it was so primordial. And I was like, yes, you're doing it. Like, this is what you're supposed to be. And then, like, so she was just, like, in her own space, doing exactly what her body was telling her to do. And she doesn't remember doing any of that. Because, again, she was in a different headspace. And her baby came out in, like, 15 minutes or less. Mm-hmm. Like, I was there for, like, 20 minutes before the baby came out. Baby came out, and it was, like, a little unresponsive, too. And, like, they had to, like, reach in and, like, pull the cord around the neck and stuff like that. And so, but she was super chill. She was like, he's fine. Like, literally, he came out, and she was like, and then they, like, took him, and like, she turns to her partner, and she's like, he's fine. Just straight face. And they're over there, like, doing all the stuff, trying to get the baby to, like, move and breathe and stuff like that. Yeah. And I'm freaking out a little bit, because I'm like, oh my god, what's going on? And then the partner walks over and does that, and I'm staying here with her, which is another great part about a doula, is that, like, the partner can go do baby stuff, or they can watch the baby being born, and there's still a person holding here, or they can be up here and you can be down holding a leg, and like that other set of hands kind of idea. But he's over there, and she's like, hey, can I see my placenta? Like, there's like just craziness over here, and she's like, hey, I realized...
She's like so chill. Like, she's just like, I did it.
She's like, I'm good.
I'm fucking done.
I'm good. Yeah. She's like, can I play with the placenta? And they, like, give her a glove, and she's, like, literally, like, they're, like, getting the baby to move, and, like, all of a sudden baby cries, and she's like, told you. And, like, she's, like, going through the placenta and being like, oh, this is so cool, and everything like that. Yeah. Oh, my God. So she's just, like, playing with her placenta while, like, everybody's, like, freaking out about her baby. And she's like, no, my baby's fine. I know. My baby's fine.
That's amazing.
And, God. Her recovery was so much better, and her you know what I mean? Like, and that was her, healing birth, so to speak.
Yeah, absolutely. So we as women, I think, have all these preconceived ideas of births that we want. And babies come when they come, and they get the type of births that they ultimately get.
Sure.
Why do you think women think they fail when things go awry?
I mean, I think humans in general think they're failing when anything doesn't go their way. But I think women are so culturally programmed to have to be perfect in this frame set, and men are trained to be perfect in this frame set. That having a raw experience is inherently a failure. Like so many women in birth are like, oh my God, I'm so sorry I was rude to you.
Oh, yeah.
And like the nurses are like, number one, that's we expect it. Number two, you weren't. Number three, don't worry about it. That's not your problem. Like, so we're worried about like, yelling at people or being too intense or too this or too, know, too raw with our emotions during a time that's supposed to be super raw and intense and, emotional. And so you're holding yourself back. And again, that's that holding. You're holding, it's that chi stagnation. You're creating that chi stagnation that holds your baby in. I think that's part of why women think they fail. I think also we have cultural expectations that are built upon our society of hyper-individualism and lack of community. And we are a pack animal. And there was a study that in hunter-gatherer societies, on any given day, there are 14 people in the caregiving role of your child. Not including you.
It takes a village.
And now it's 1, 2, 3 if you're lucky, maybe 4. It's not enough. You're not supposed to you are not built to do it yourself. You're not supposed to do it yourself. You're not built to do it yourself. It is against our physiology.
You should put this on like a loudspeaker.
Yeah.
Just like blare it out to the people of Rochester.
Yeah, like
to the world.
This is not your fault.
Yes.
We live in a society that has programmed us and trained us to think that we're supposed to be able to do it alone. And we're supposed to be able to do it with one person, 2 people, 3 people.
Yep.
And we're not.
Yep.
And we're also not exposed to birth.
Totally.
You're not hearing the person in the hut next to you give birth. You're not seeing the lady down the road give birth. You're not seeing your mom give birth to your siblings. You're not seeing your aunts give birth to your cousins. You're not seeing your older sister give birth to,
Yeah. You're like desensitized.
You were desensitized. And so our cultural exposure to birth is through like fucking TLC and like
I know.
And like high drama.
I didn't know I was pregnant.
Yeah, like high drama, high intensity. Because watching a woman go like for 4 hours is probably boring to everybody else, So they're not going to show that on TV.
Yeah.
They're not going to show that in movies.
She's very peaceful. She's very serene, but she's just swaying for 4 hours.
Totally. You're not going to see this woman like sitting in a tub with her arms up like this, going like,
yeah.
And then all of a sudden the baby comes out.
Meanwhile, this is like magic to you.
Totally.
Yeah.
But like, they're not going to show that on TV. They're going to go like, well, the doctor came in and saved you because you have all these problems, and here's this beeping machine, and we got to cut you open immediately, and like, here's this drama. And so our culture, or, we watch a movie, and all of a sudden it's like, oh my God, my water broke. And then it's like a comical car race to the hospital while she's screaming
running
in the
red
back
light.
seat. And then all of a sudden, like, she's in a hospital gown screaming, and then she's holding a baby.
Yep.
And that's our exposure. And so we think that that's what birth is.
Woof.
And then all of a sudden we learn that, like, sometimes water breaks and, like, literally nothing happens. And or your water doesn't even need to break. Technically, the baby can be born without the water bag ever being broken. It's called born, like, in the veil. Yep. And so, like, we just have these misconceptions because we're not exposed to real physiologic birth. And it's also one of the big problems within obstetrics and, midwifery less so, but still midwifery is that, like, there's no exposure to zero intervention. And when I say zero intervention, I mean zero intervention, physiologic birth. And so when it happens, they go, I don't know what to do.
And there's nothing to do.
And that's the thing is, like, when we are providers, me and you, and OBs and midwives and everything.
Yep.
We are trained, again, to recognize and treat pathology. When we are involved in a physiologic function where there is inherently no pathology, what do we do? Nothing. The answer is do nothing. But it is so hard to do nothing. It is so hard to do nothing.
Yes.
If a
Because we're
patient
doers.
because we're doers. That's why we got into this, is because we want to help people. But to help people, sometimes you got to get out of your own way so that they can get out of their own way.
Yeah.
And so, like, if we have a patient that comes in for acupuncture, you know, like, actually, I just saw this, like, young kid yesterday. He's like, oh, I get all this calf tension, and I, like, strained my hamstring, you know, playing lacrosse or something like that. And I'm like, oh, is it, like, your senior year? Is this, like, a big year for you? Like, I think there's an emotional component to your calf tension, you know? Like, when you're stressed out, I'll bet your calves get tight, you know? That's me in a clinical setting getting out of the way. That's me doing nothing, is going, like, I think your problem, it's not made up, it's very real, it's not in your head, it's created by your head. But in order to resolve this, like, I can put needles in there, and I will, but, like,
in a sense, you're handing it back over to them.
This is what you need to work on in order to get the calf to relax. You know, it's getting out of the way. I like to stay very quiet during labor. Like, I don't really feel like I need to talk. Especially during contractions. I think when somebody's in a contraction, you don't talk to them. You don't ask them a question. You don't make noise.
Yep.
There's no need.
Yep.
It pulls them out. You don't want to pull them out. And so oftentimes one of the biggest things that I do is I literally just take a hand and I very gently, like gallbladder 21, like top of the shoulder, just press a little bit. I'm not digging in. Just press.
Yep.
Because so often the contraction is making them go. And they don't need you to go, drop your shoulders.
Right.
Relax your forehead.
Yeah.
Breathe.
Yep.
What they need you to do is that.
Yep.
And then their body goes.
Yep.
You didn't have to say a damn word.
Right.
You didn't have to say anything. You didn't have to do anything.
Yeah.
You just went, doot.
Yep.
And their body went, oh yeah.
Yeah, all these things are so subtle, right? We're not talking about huge interventions. We're talking about really gentle, really kind of calculated but relaxed types of interventions.
Yeah, you're guiding. You know, it's that guidance.
Yeah. Well, hey, Patrick, thank you so much for joining us. Gosh, you are doing such important work out in Rochester. Thank you. And also, I want to plug your practice.
Oh, thank you.
Patrick owns a New Life Acupuncture. He serves the greater Rochester and Spencerport areas, and he specializes, so he does do a lot of labor delivery, but he also does hormonal health, fertility, he does postpartum, and also peds, which I think is really amazing. Women and children. It's it's.
I do a lot of menopause.
That's awesome.
I love treating menopause.
Yeah, that's so great. So thank you for joining us, Patrick.
Yeah, you're so welcome. Thank you.
And I hope we can do this again sometime.
Absolutely, totally. I mean, I can talk for literally days on
Me too.
anything. I never shut the hell up.
Me too. I have the gift
yapper.
of gab, which is why you should have a podcast, Patrick.
I know, but...
Because you can just talk and talk and talk. All right, well, thank you so much for joining us, and we will catch you in the next episode.